So imagine for a moment it's 1902, and we are on Governor's Island in New York, and we want to get to London in less than a day. And all we have are boats. And even the fastest boat takes a week to cross the Atlantic. But what would we do? Well, we'd be tempted to call the boat builders together for an innovation conference, maybe a little like this, but with less fancy AV. And we would give some money away to study the tides and study the currents. We would maybe work on streamlining the hull. We would work on building bigger and faster engines for our ships. And the problem, of course, that we know now is that no matter how hard we try, we can never get across the Atlantic in a day. Even today, 100 years later, the quickest ships take 3 to 4 days to cross the Atlantic. And what we need is not to innovate upon the current design, or actually I would call it improve on the current design, but actually to innovate, to actually come up with the airplane. So I would postulate we are at that point right now in healthcare. But our healthcare system, despite in many ways being excellent and making miraculous saves, but in many ways it seriously underperforms and performs extremely and embarrassingly poorly. So patient experience, we wait too long, we suffer too much, we too often are treated with less than dignity when we experience the healthcare system. We're treated in ways that we would never tolerate in any other industry. Our outcomes are embarrassing. The defect rates are high. The 30-day readmission rate for Medicare is 21%. 21%. So 21% of the time when you're a Medicare patient, you leave the hospital, you are back within 30 days. Right? That number is never going to be zero, but 21% is embarrassing. And it's done at a cost that's really obscene. So this weekend, I was talking to a friend who's uninsured. She ended up having a minor problem. She went to see a primary care doctor in a big teaching hospital, had a few tests, spent maybe 20 minutes of her time, and she got a series of bills in the mail totaling $1,800. Right? In any other industry, that would be fraud. And we do this routinely in healthcare. So between the healthcare we have and the care we could have lies not just a gap, but a chasm. That's not my words. That's the Institute of Medicine, 2001. Crossing that gap, I would postulate, it is so big, that chasm, it's more like trying to get across the Atlantic in a day and not a week. And so maybe what we need to do is go beyond studying the tides and streamlining the hulls and building faster engines for our boats. And maybe we need to spend some of our time actually trying to build an airplane. So what does that look like? So I've been doing this for the past 10 years or so and decided to start with primary care for many of the reasons that John mentioned. It's the first place that most people contact the healthcare system. If we do it right, we can help people manage many of the common chronic conditions that are driving a lot of the morbidity today. And we can also help people navigate the rest of the healthcare system, make the right decisions in this system or non-system of ours. So what does this sort of model look like? And we've been iterating on this airplane design for a while. It has 3 big components to it. The first is the payment model. Right now, as most of you know, the way we pay for primary care, indeed the way we pay for most healthcare, is fee-for-service. We pay per thing we do. Guess what happens? We get more things we do. We don't get help. So what we decide to do is, let's stop the madness. Let's pay us a flat fee for primary care. Let's get rid of this whole fee-for-service billing thing entirely. All the games about coding level 3s versus level 4s. Just pay us a flat amount of money and let us take care of patients. The second part of that is primary care is currently 4% of the healthcare dollar. 4%. So I'd argue that 96% of what we do is failure of primary care. And that's sort of a really silly investment philosophy. So we decided, let's just change that, and you give us, double down on it. Give us 8% of the healthcare dollar. And all we need to do now is, through better primary care and better management, save 4% of total healthcare spending, keeping people out of the hospital, out of the emergency room. Ask any doctor, could 4% of the people in this hospital not be here if they had better primary care? Absolutely. And the third piece we do on the payment model is we put these co-payments on primary care. You have to pay $20 each time you come into the office. The obvious question is, what do co-pays do? They deter people from doing things. And why exactly are we trying to deter people from going to primary care? Right? When the cost of not going to primary care could be going to the emergency room or the hospital, which is much more expensive. So Pay us a flat fee, stop the coding games, put more money into primary care, and stop with these silly copays. Now that we have this different business model, we can do the second thing, which is completely change the payment model, the delivery model of care. And what does that look like? The first is really build a team around the patient. Managing your health is hard. And it's not just up to me, the doctor, right? And so what we have is a group of people called health coaches who we draw from the community, who speak the language of the people they serve, who can work with patients one-on-one in person for all the hard things about managing your health. Making a plan, learning about your disease, knowing what to monitor, who you can call for help, keeping you accountable. It's a little what the disease management companies have tried to do with their nurse in the call center in Idaho, but it's done so much better in person, in your doctor's office, with real clinical data and a real face-to-face relationship. Every day we spend 45 minutes at the beginning of the day talking about our patients. Who's in trouble? Who do we need to help? We allow patients to interact with us not just face-to-face in visits, which we do, but also by telephone, by email, by text message, by video chat. We do a lot of groups. Groups are a great way for patients not just to learn from us in an efficient way, but also from each other. We spend over half our time proactively managing people, calling and checking up on people, as opposed to waiting for them to come in when they get sick. We integrate mental health into the practice because this silly dichotomy of mental health and physical health doesn't work. And if we don't address people's mental health problems, we're never going to fix their physical problems. And then we aggressively co-manage people with specialists and hospitalists. Our job is to manage them no matter where they are in the healthcare system, not be a fancy triage desk. So if you do this sort of different sort of care model, what you realize is the third part, is that the technology you need, the IT systems, are critical, but the things that are out there, the electronic health records, are awful, right? They're built for today's practice, and what they're built to do is help you document, code, and bill higher. Doesn't add value to anyone. So what we learned is we needed to build our own, and have started building our own IT platform to help us power our practices that will allow us to actually engage with our patients, let them see their whole medical record, it's their record, allow us to manage our teams proactively, and allow us to manage the population. This is not just a blueprint. We've been actually building this for the past 10 years. We started with a prototype practice outside of Boston. Since then, we've worked with a number of progressive health systems, Virginia Mason and the Everett Clinic in Seattle, in a project with the Boeing Company, Atlanticare, which is a health system in New Jersey, in Atlantic City, in conjunction with the Casino Workers Union there, the SEIU in Baylor, in Houston. Since then, we've actually decided that actually working with health systems, who are essentially shipbuilders, is difficult. They find it hard to get out of their own way. So for the last year, we've been actually building our own practices from scratch and owning and operating them ourselves. And we have a practice in Las Vegas, Nevada, across from the stratosphere. We have one in Hanover, New Hampshire, working with Dartmouth College as our sponsor, and one in Brooklyn, New York, working with a group called the Freelancers Union. Now, the shipbuilders, as you can imagine, aren't always thrilled with people trying to build airplanes. We've been accused of raising expectations, making other practices look bad, and upsetting the status quo, all of which we plead guilty to. I've had angry people say, how are you going to make whole those doctors for whom you are taking their patients? And the obvious question, of course, is it's not my problem. And I don't think it should be any of our problem, really. I think we forget often that the point of healthcare should be to serve our patients, not ourselves. So this thing works. You know, our models work. Patients absolutely love it. We track our patient satisfaction using a thing called the CG CAP survey and net promoter scores, and they're through the roof, as you can imagine. Outcomes are better. We can lower people's LDLs if they have high cholesterol. We can improve blood pressure. We can improve diabetes. We can get about half the people to quit smoking. We can erase racial disparities. People come into the practice who are Black and Hispanic with higher LDLs and A1Cs, and when they're in the practice 6 months, those differences go away. On the economic side, primary care costs more, but that's part of the model. Drug costs are a little higher because people actually take their medications. But what you find is that total outpatient costs drop by 25%, ER visits drop by 48% relative to a control group, and hospitalizations drop by 41%. Net spending goes down by 15% or so. Again, that's not lowering the slope of the curve. That's dropping healthcare spending through delivering better care. The way we do this seems theoretical, but let me make it real to you with patient story. I have the pleasure of not just running the company, but also serving as a doctor in several of our sites. So we had a patient who came to see us. Her name is Sharon. And Sharon was 60 years old when I met her. She was from Revere, Massachusetts. It's a working class town about 40 miles north of Boston. She was a single mom, had raised 3 kids by herself. And when she came to see me, she had a chart the size of the phone directory. Her major problem was COPD. She had had a 40-year history of smoking, and her lungs were awful. She was on every inhaler known to man, chronic steroids, and home oxygen. She also had diabetes, hypertension. She had had a minor heart attack. She had had a pulmonary embolism, a blood clot in her lung, potentially had squamous cell lung cancer, had had reflux, osteoporosis, and I'm probably forgetting some. She was on 27 different medications when I met her. She had spent 3/4 of the prior year in and out of hospitals and rehab. The quarter of the year she wasn't in an institution, she spent most of her days going to follow-up specialist visits. She had accumulated specialists, sort of like barnacles on a ship, through going through all these various hospitalizations of hers. And each of these visits would take a day in itself. It would take her an hour just to get ready because she got out of breath so much. She'd take another hour to walk to the car. She'd have to drive into town, obviously wait in the waiting room for the doctor, see that doctor. Each one of her daughters had to take a day off from work or get a babysitter each time this happened. There was no overall plan. No one had any idea what the big picture was. Each doctor tried to do their own thing, but never talked to each other. She did have a primary care doctor who saw her once for 15 minutes, took one look at her chart, threw up her hands and said, "What can I help you with today?" and gave her an antihistamine because of some allergies. So, Sharon's outcome was awful. And it's sort of an extreme case, but there are a lot of people out there like her. So her daughter heard about our practice and asked if we could take care of her in her primary care. I said, absolutely. First thing we did is we actually read through her chart, and myself and our health coach went to her house, had her daughters meet us there, and spent 3 hours figuring out what was going on, reconciling her medications, making a plan. Actually threw out 20 of those 27 medications because she didn't need them. We fired 10 out of her 12 specialists and said, you're only going to see 2 of them. I called those 2 up personally and said, we're going to talk every time you see her so we know what's happening. Over the next several months, our health coach, Kelly, and myself spent a lot of time with Sharon and her family, explaining her condition, figuring out goals of treatment. We finally decided that we would actually shift into more of a palliative care mode, that our goals of care would be to make her comfortable. We were not going to fix her underlying lung problems. We had a weekly conference call with the family, just for 10 minutes, just to update people on the plans and where we were. Now, Sharon's disease didn't get better. Her disease was still awful. But she spent most of the next year at home. She had only 2 hospitalizations, and she spent Christmas, Easter, and New Year's in her house with her family, which is what she wanted. About a year later, her disease took a turn for the worse, and on a beautiful September afternoon, a little like today, she passed away very peacefully in her own bed with the 3 daughters by her side. So there are a lot of people who would say that this sort of care is unsustainable, it's unrealistic. But the bottom line is, Sharon cost the system $200,000 a year before we got to her. And this, economically, makes all the sense in the world. But maybe more importantly, if you were Sharon, or Sharon with your mother, this is exactly the sort of care that you would want. And I don't know why we keep making excuses or tolerate not being able to provide this sort of care. Between the health care we have and the care we could have lies not just a gap, but a chasm. If we want to cross this chasm, maybe it's time we stop putting all our attention into studying the tides, streamlining the hull, or building better boat engines. Maybe it's time we get the courage to learn how to fly. Thank you.
So, listening to that, is health a chronic condition in the same way that, say, COPD or diabetes is a chronic condition?
Yes, we often say that life is in some way the chronic condition, yes.
And so the strategies for maintaining the health of a patient you would see only once a year because there's nothing wrong with them are not that much different from the strategies you would use to maintain a patient who has some sort of traditional chronic condition like diabetes or consequences of obesity or kidney disease, something like that.
Yes, you're exactly right.
So the incentives for you being involved in any of these particular patients' lives are radically different, correct?
What do you mean?
I mean, you get compensated very differently for your involvement with someone with chronic kidney disease versus someone who needs a yearly checkup, right?
We get paid a fixed amount for the primary care we deliver to people. And it is risk adjusted in some ways, but our job is to manage the population. I think one of the big differences between our practice and typical practices is typical practices, even good ones, people believe my job is to do the best I can for each person walking in front of me. And I code and I bill for it and I move on. Our perception, every single person in our practice believes our job is we have a group of 1,000 patients and they are our responsibility. And it's our job to keep them out of trouble, whether it means improving their health or improving their COPD.
Now, do they think of you as someone who's on retainer for them on some level? Do they think of you as just a smaller bill than some of the other things they might pay for? How do they create a sense of what this relationship is versus fearing, oh my God, I'm going to go to a doctor and it's going to cost me a lot of money and I don't necessarily know what the benefit is, short of being in the middle of a crisis?
So in our practices, our patients don't pay anything. So the way we work is we work with self-insured payers, Dartmouth College, the Union Trust, the Freelancers Insurance Company, and they pay us to take care of patients. So there's no money that changes hands between ourselves and our patients.
So how do patients understand that you're different from other doctors' offices and practices? Because in some sense, they need to understand how different you are to raise the expectations so that all primary care physicians will respond to what they're supposed to do when patients walk in the door.
Yeah, and so the easy answer is when they hear from their friends who come to the practice that this is completely different than a typical practice, they get it. And again, the difference isn't me. I think a lot of the redesign around primary care focuses around the doctor, and I'm a tiny part of it. It really is about the whole system, and in particular about the relationship they have with the health coach.
So how do you apply this to populations that might be underserved or individuals that fall outside of the traditional insurance model, or people who have just done things in a particular way for a long time and maybe are difficult to get to change?
Yeah, we, in some of our practices, the one in Las Vegas, we select the most difficult patients. We actually go after the patients who are the highest cost and who are the hardest to change. Because they're where we can
How do you do that?
So what we do is we run claims data on those patients. We find the people who are in and out of the hospital, in and out of the emergency room, and those are the people we reach out to and invite to join the practice.
Can you explain how a conversation like that goes with an individual who is high risk, high cost, and someone who would be described as something of an incorrigible patient in terms of compliance?
Yeah, so we ban the word non-compliant in our practices because it behooves us to figure out why they're not doing what they should do, right? And shame on us if we don't figure that out. I think too often we do the easy thing and just blame it on the patient. Often it's that there's their social needs that are taking higher priority for them, and then we need to fix those social needs. We'll never take care of the medical needs. It could be that people don't understand what the consequences are. It could be that there are substance abuse or depression that's clouding it. So again, this sort of they're hard means that we have to work harder to figure out what we need to do to fix the problem. And again, the key thing that matters is the relationship. Little anecdote, we have a patient in Atlantic City who was awful. She was out of control diabetes, out of control hypertension, not going to work, in and out of the ER, came into the practice, and then 6 months later was on the straight and narrow. Blood pressure was fine, cholesterol was fine, no ER visits, back to work, taking her meds. I went to her and said, so what is it that changed? Was I a great doctor? And she said, well, all due respect, doc, it had nothing to do with you. My health coach, Millie, cared about me. She taught me to care about myself. I didn't want to let either of us down. And it was that simple.
Who was the person that intervened?
This is the patient. So the patient's my health coach, Millie.
My health coach,
yes.
Millie. Now, how do you go about getting a health coach?
So we hire health coaches. So our practices are based on the model that if we want to engage with people, particularly hard people, we need to find human beings who can do that. They do not need to be healthcare trained. The only skill you really need is to be able to be engaging in care. So we find them from all over. Our best health coach in Atlantic City worked at Dunkin' Donuts before we got her. Our best health coach in Las Vegas was a cashier at Target. So we can find them anywhere.
How did you recruit?
We ask people we know. We ask our patients, do you know anyone who would do well? And our patients get it. They understand who we're looking for, and they send us people.
So in a sense, this is a little bit like the last mile problem in so many endeavors, where you can have all the great programs, you can have all the fabulous doctors, you can have spectacular gadgets and training, but if you can't get the information out to the people who need it at the time that it's needed, that last mile, it's zero.
Exactly right. So what we see our value is what I call an effector arm, which is almost exactly that, is that there's all this great data floating around in healthcare, all these great programs, great technology. If we can't actually deliver that to individual patients, it doesn't matter.
All right, so what's the takeaway here then? How do you create a system that encourages the development of a career called health coach? That would include training. Maybe we don't want to do the certification model. Maybe we don't want to make the same mistakes. But how do you encourage people to go into something that, based on your experience, is so completely critical?
Right. So we create the jobs for that. Right. So I think you create the demand. So in our practices, for every doctor, we have 4 health coaches, and we create jobs, and we go and find them, and we hire them, and then as we grow the practice, we get more of them. I agree with you. I think the certification route's the wrong way to go. I think we'd end up recreating what we have now. What we're thinking a lot about is how do we create career paths for these health coaches. It makes all the difference in the world, and I think they're also great for the people who are the health coaches.
So in a sense, you're deputizing people who have a set of values and giving them an opportunity to express their natural caregiving ability in a way that produces productive outcomes for your practice.
Right, the technical term for it is called conferring agency. What we do as the docs is confer agency upon the health coaches, then they're able to what's called confer agency on our patients.
Now, I'm just thinking, and maybe it's just because I'm kind of a skeptical journalist sort of guy, that when you go to talk with, what's one of the main insurers you work with?
The Dartmouth College.
Dartmouth College, okay. There's got to be some well-meaning and spectacularly wonderful, but still accountability guy at Dartmouth Insurance, right, who comes in and says, who are these people? These health, what do you call them? We're not paying for this.
So that's exactly why we don't let them pay us fee for service. We say, you trust us to figure this out, you pay us a fixed amount of money, and we'll figure out how to do it, and it's frankly not your business how we do it. So they let us decide, we the provider decide how to take care of people and not have the insurance company try to micromanage that.
When you think about this model, what are the limitations in its scalability? Are the incentives based on how you've been able to grow because the service, as you say, they hear from their friends that it's so good that attracts a market to you? Is that the mechanism, or does there need to be some other kind of intervention to make primary care along a model like this more generalizable and more available?
So I think there's no reason why what we're doing is not more generalizable if people are willing to take the leap. And again, I think it's one of these hard things that you need to be willing to change an awful lot of things in order to get there. Right now, our constraint to growth are finding payers who are willing to pay us differently to do this. We have no problem finding doctors who want to work in a different model. This is a great way to practice. It's a lot better than being a typical primary care doctor. It's hopeful and you can make a difference. We have no problem finding health coaches. We're actually having no problem attracting patients. So we can attract patients as fast as we want to when they see a different model.
All right, then last question. Describe a meeting where you tried to make a deal with a payer and the deal didn't work out. I mean, I suspect you could possibly have heard, well, we're going to go in a different direction, Mr. Fernandopulle, is it?
Yeah.
Is that how it worked? Or were you competing with an existing model that was able to underbid or had some sort of competitive advantage? Describe a situation that did not work out, where you were counting on and wanting to get a payer and it didn't happen.
So there are a number of reasons why payers decide not to do this. So we currently don't work with any health plans. If you notice, all the people we work with are self-insured employers, essentially. And we essentially do an end around the health plan. They pay us directly through the employer, and everything else stays with the health plan. The problem with health plans is they're afraid of upsetting their network. As you can imagine, some of the existing primary care doctors in town don't like new competition. And so any payer who's afraid of upsetting existing doctors has trouble signing up and working for us.
So the nut to crack for you, to add another last question here based on what you just said, the tipping point would be to get a health plan to adopt this style of primary care. And then we might be in a situation where it would scale up rapidly.
Right, no, exactly. So at the moment, what we do is we go after early adopters, the people who actually feel the pain of healthcare costs and poor health, which is people, large self-insured employers in a single geography. I think if we want to scale broadly, the next step would be taken to health plans.
Rushika Fernandopulle, thank you so much.
Great, thank you.
Thank you.